So my topic is that how do we do TAVR normally with a single groin access. So I just will highlight that. So this is, all of you do TAVR, and if you do enough of them, they all are very similar. So the idea is that you have to have a standardized process to say how we do the TAVR. So one of the things that we normally do is to create a slide like this and project it in part of one of the monitors in the lab, so at least you know all the information about the patient. So this is, I think, a very useful thing, at least for us, to say that what exact patient we are treating, so that you don't forget. And that's why it has all the numbers, all the things. So CT scan, coronary heights, vasculature, valve, similar to what you would do, but at least it's available immediately for your review while you're doing these things. This is our room, and so this is where we do our TAVR, but very simple, nothing, no invasive things, of course. And so the access, how do we do it? So this is something important, something different than most people do, is one, just stick the first catheter at the height just below the inferior epigastric. And usually I myself don't use the ultrasound, but if you want to use ultrasound, it's a good idea. So you can use ultrasound. But usually I use the way to do it is to say that where you see the blue thing and the red thing. So red is where the bifurcation is, blue is where the inferior epigastric is. So fluoroscopically, I would know that where the arteries are, and that's how we stick it. So once it is stuck, you put just one perclose in the groin artery, then put an 8 French sheath in the superior puncture, and then just manually 2 finger breadths below stick it the artery, and so you know that where the artery is. And as you can see, we documented that that's where we have stuck it, the second artery, a second sheath, and so this sheath is then a 5 French sheath. So you put a 5 French sheath underneath, and then of course you put a pacing wire. So as you see in the groin, we have a 8 French sheath, 5 French sheath, and then a venous sheath, 6 French. And then of course we use a sentinel, so that's why there is a radial artery sheath in the right wrist. So this is the typical access for all our patients in the groin. And then we like to use a straight flush catheter. So in the bottom, we first put a straight flush catheter. So it's important that before you upsize the top, we put a straight flush catheter in the bottom. And then there is our anesthesia people or in the people in the cath lab, they require a monitor. So I make a little manifold there so they can monitor the pressure, draw the ACTs and things like that. And then the sentinel. And so this is how it looks. We had a biplane room. So we have a biplane cath lab. So this is how the monitor is set up. That one slide is there in the corner, hemodynamics, and then the echo will show up in that monitor on the top. So we always measure the hemodynamics. So this is very important to say that where the dicrotic notch is, just for fun, you should know that when the dicrotic notch, when you deploy the valve, the dicrotic notch typically comes down a little bit. And if it is below the halfway, then most of the time it is good in the downsloping term. And if it's much above, then the valve is closing fast enough. That means either there is AR or the aortic stenosis has not resolved enough. So this is something important to keep in mind. And then I usually like to do, if there's a single plane, I would like to do the RAO caudal view such that we don't do a cusp overlap method, but to say isolate the non-coronary cusp. So you don't have to do exactly the cusp overlap, just isolate the non-coronary cusp, make the valve coaxial in the sense that take out the parallax, and then wherever the radiolucent line is for the Edwards valve or for the self-expanding valves, we can use this view to line the bottom of the valve where we want to put the valve. If you are interested in preventing the second valve, so then you will align the top of the valve below the left coronary in the LAO projection. And then we deploy the valve and then we check it. So again, you see that we use the straight flush catheter, not a pigtail catheter. So you don't have to remove the catheter. So leave the catheter in the same place. And then I inject a little bit of dye to make sure that where we put it, so document it that where we wanted to put the valve, we have placed it. So typically we like it at 0. Again, depends on the patient to say that where we want to put the valve with considerations. Like this patient, it would be difficult to put a valve in valve because we put the patient high valve. And then I personally like to do a little bit of echo with the low aliasing velocity to make sure that there is no aortic regurgitation. And do, of course, an aortogram as I showed. Dichrotic notch, as I mentioned, that we would measure, and diastolic pressure. So it's flat, it's not coming up. The LV pressure, very important. And then we rapidly pace in the bottom to make sure that if you take the pacer and put it in the RA, rapidly pace, we can discharge the patient. So if the rapidly pace at 120 beats per minute, so we start at 90, 100, 110, 120, 120 we conduct 1-to-1, then it is unlikely that they will have a heart block. Then we take out the sheath to prevent the vascular complication or anything. So just one per close. We take the blood sheath out. Sometimes we leave the wire in and take a picture, or we can just take a picture with the manual pressure for the bottom sheath. Most of the time, 70% of time, after one per close, we put an angiosil to cover the bottom artery. We did this, so same day discharge, we are able to use it in about 50% of our patients. And readmission rate and all the outcomes are similar. We see them the next day morning, however, just to make sure that the groin is good and the ECG is stable. And if they have higher gradients, then we give them anticoagulation. Otherwise, typically we don't, just single antiplatelet therapy. We did publish this, so if you want to read about it, that what the unilateral access is, we have compared unilateral access to bilateral access. This is, of course, small number of patients. This was in 2017 patient group. Now we have long data, lot of data, and it's very easy. If the artery does not look perfect, you can dilate it. So it's very simple to put a sheath, same bottom sheath, put up to 6 millimeter balloon. You can put it from a 5 French sheath. If you want a larger, then you can put a 6 French sheath and put up to 7, 8. If you want to put a stent, you can put a stent from the bottom. So all of those things are easy, fast to do. And single versus double per close also we compared, and we thought that both give very similar outcomes. So we are using single per close, and in about 30% of patients, we don't have to use a second one. So this is also cost saving in that respect. So unilateral access is simple, feasible in most patients. It allows for rapid evaluation of the access site, allows for easier balloon inflation and stent placement if you have a problem. Patients like it because they think that there was no other groin instrumentation. And it may be difficult to manipulate the catheter sometimes, but the best way to do this, if you have a difficulty, just put a stiffer wire and then you can move it. So there is no real challenge by using this single access.